I hope you can hear me well. This is the first time we're trying something like this, so please bear with us. But hi, I'm Julia. I'm the co-founder of the Barbados Association of Endometriosis and PCOS, and I'm also currently the public health and advocacy manager of the organization. So I'm not a doctor, but I am a PCOS awareness advocate. And as we are recognizing PCOS Awareness Month in September, we knew it was important to share as much information as possible about this condition. So we are really thankful to the Barbados Fertility Centre for providing this. It's a pre-recorded webinar. The medical director, who is a doctor, Dr. Juliet Skinner, outlined several aspects associated with PCOS, which is Polycystic Ovarian Syndrome, for those of us who might not be aware, in the recording. So please feel free to, you can either forward your questions to us after at our email address. The link is located below for our website, and you can also be linked to the Barbados Fertility Centre's website also. Or you can utilize the chat here and ask your questions in real time. We will try to the best of our abilities to facilitate your questions. We know that this resource will be of great use to you or to someone you know. And again, for further information about the Barbados Association of Endometriosis and PCOS, BAPE for short, or the Barbados Fertility Centre, we have links in the bio below. So I will start the webinar now, but once again, thanks for joining us. And remember that there is hope with PCOS.
Hello and welcome to our webinar entitled How Do Polycystic Ovaries Affect Your Health and Fertility? I'm Dr. Juliet Skinner and I'm the Medical Director of Barbados Fertility Centre. Millions of women in the world are diagnosed with polycystic ovaries. PCOS is a complex heterogeneous disorder of uncertain etiology, but there is strong evidence that it can, to a large degree, be classified as a genetic disease. And this is what you will find if you Google this having just been diagnosed on Wikipedia. Let us look at a few PCO facts. It was first described in 1934 by Stein and Leventhal and initially was referred to as a syndrome bearing their name. It is characterized by chronic anovulation and hyperandrogenism, and it is a common medical condition affecting some 5 to 10% of the population. In 2003, a famous consensus workshop in Rotterdam worked on coming up with criteria to make the diagnosis of PCOS. And what they suggested was that 2 out of 3 criteria need to be met: oligo or anovulation, excess androgen activity, or evidence of polycystic ovaries by gynecological ultrasound. In practical terms, this means that the diagnosis of polycystic ovaries may be made on symptoms, such as irregular periods, acne, hirsutism, weight gain. It may be made on the basis of blood tests, so biochemically, with a high LH or inverted LH-FSH ratio, elevated testosterone, or indeed, most commonly, based on the ultrasound appearance of the ovaries. On the right of this picture is a picture of a polycystic ovary. These ovaries are slightly larger than usual. They have lots of primordial follicles, which are the black circles you see in the picture, but these tend to be peripheralized, almost like a string of beads around the outside of the ovary. The central stroma tends to be dense, and likewise the capsule may be quite obvious on ultrasound. It is a very heterogeneous condition, and by that we mean that there is a massive range of your patients that might exhibit mild symptoms of polycystic ovaries, where they will get regular periods, where the hirsutism might be really quite minimal or non-existent, acne similarly mild, they may have a normal BMI, and indeed these ladies may well be able to conceive naturally. However, on the other end of the spectrum, we may have patients that have severe disease, where they do not have any periods naturally. They will be markedly hirsute, marked acne, and they will be obese. and for these patients they will very rarely conceive without help. There is no doubt that PCO has a significant impact on the quality of life. Body image psychology, depression, these have all been linked to patients having a higher prevalence in patients with polycystic ovaries. There's also very important long-term implications of the disease or condition. 50% of patients with PCO will develop diabetes at some point in life. And in terms of cardiovascular disease, there's a 4 to 7 times higher risk of this, of heart attacks, increased cholesterol and blood pressure. Because of the high estrogenic state, there's also an increased risk of endometrial cancer, ovarian cancer and breast cancer. So for a moment, let us think about what would be the guides to management for a woman not wishing to conceive. And broadly, these are general management options to control the periods, manage the hirsutism and acne, and control her weight. For women not wishing to conceive, it is very important that weight loss is crucial. And obviously this can be done through diet and exercise, medical agents or bariatric surgery. In the case of a diet being chosen, there's also evidence to suggest that a lower carbohydrate diet will tend to work better for women with polycystic ovaries. With regard to cycle regulation, this can be done by the use of a contraceptive pill, and in particular those with anti-androgenic properties such as Diane or Yasmin. In addition to the pill, management of these aspects may be through topical hair removal or anti-androgens. For those ladies that unfortunately suffer with male pattern baldness or alopecia, we can use minoxidil, and certainly we are well aware now that there is a role for metformin. Metformin is used to treat type 2 diabetics, and it affects how insulin controls glucose and reduces testosterone. It improves menstrual cycling, it slows hair growth, it reduces body mass, and it reduces cholesterol. It also may improve ovulatory ovarian function, and indeed it reduces the prevalence of gestational diabetes when we use this in a pregnant patient. So let us now turn to management of women with polycystic ovaries who actually want to become pregnant. In order to become pregnant, a lady needs to recruit follicles that she was born with, and a series of hormonal changes need to occur which induce the ovarian change of a recruited follicle, culminating in the release of a mature egg at ovulation. The medical definition of infertility is failure to achieve a pregnancy within 1 year of unprotected intercourse. When a couple are not becoming pregnant naturally, it is conventional to do a primary diagnostic screen, which would include a test of ovulation, a test of tubal patency, and a semen analysis, at a minimum. It is important to remember that when a couple are not achieving a pregnancy, that the underlying causes of infertility can be male, female, or in quite a significant percentage, indeed a combined answer. The treatment options for infertility include ovulation induction, intrauterine insemination, and in vitro fertilization. So let us now turn to polycystic ovaries and infertility and look at its impact and the potential treatment options and approach that we take. Anovulatory infertility is extremely common in women with polycystic ovaries. In fact, 95% of women with polycystic ovaries do not ovulate regularly. We need to use a treatment to promote the recruitment and the release of the eggs, and this is referred to as ovulation induction. For patients with polycystic ovaries, the good news, however, is that we're able to do this through simple oral agents in probably 80% of patients with PCO. And in some patients who are not responsive to oral agents, we can go to second-line injectable agents, and this will also be effective in about 15%, with, yes, a small number of patients not achieving any follicular induction from ovulation induction, and for these patients we need to move to an IVF answer. With ovulation induction, it's important to understand that the goal is follicular development. That, in other words, if we look at that top picture, which is the same picture I showed you in an earlier slide, where you have all of these small peripheral small follicles, We need to hormonally induce that ovary to change into looking like the bottom picture, where you have a large, mature follicle ready to ovulate an egg. It is so important that when we use these treatments that we must monitor that patient. And ideally this needs to be by day 12 ultrasound, but certainly at an absolute minimum, a check on the day 21 progesterone to see that the patient is having a response to the medication. The first line agents for ovulation induction would include things like clomiphene citrate, tamoxifen, and indeed letrozole. And over the years, clomiphene has been available for decades at this point, and it's certainly widely available. It is inexpensive and well tolerated. More recently, letrozole has been showing some promising results, even in Clomid resistant patients. And again, there's now a number of studies to show that this is a very nice alternative choice as a first line agent. Again, the goal is to achieve follicular formation, and we should monitor that response. All of these medications thankfully are associated with very minimal or mild side effects, and if a patient is responding on that ultrasound, there is a very high chance that that patient will get pregnant within 6 cycles or 6 months if this is the sole cause of infertility. In the event that the patient is not mounting a follicular response to a first-line agent, yes, we obviously can turn to second-line agents, which are the injectable hormones. These are more potent than oral agents, and these include the FSH-LH injections such as Menopur, Marinel, Follistim, or Gonal-F, to name just a few. Yes, there is a risk of these agents that we can induce multiple follicles and therefore take a higher chance of multiple pregnancy. So there is about a 10% twin rate with injectable ovulation induction. It is so crucial to do monitoring on every single cycle to ensure adequate and not an over response. The main disadvantage to injectable agents is that of cost, which is that it is considerably more expensive, and the cost of an ovulation induction cycle in medications for injections will be in the vicinity of about $400, whereas with oral agents it's probably closer to 40. So are there any alternatives in a second line approach to injectable hormones? Yes, ovarian drilling has been around now for decades, and with ovarian drilling the concept was that surgical injury to the ovarian capsule may cause regular cycles to resume. Many decades ago this was called a wedge resection, and this was done via an open technique, in other words a laparotomy. Thankfully, for a long time we've been able to do this through more keyhole surgery approaches, which is a laparoscopic ovarian drilling. The main advantages that theoretically this may hold would be that the effectiveness at inducing ovulation and conception may last longer than the one cycle that you take your Clomid or your tamoxifen or Femara. It also has been associated with lower multiple pregnancy rates. However, the big disadvantages are that laparoscopic injury can occur to bowel bladder or viscus. And indeed, more worrying would be that if too much damage of ovarian tissue, there is a risk of premature menopause. And indeed, through the surgical healing of what you've induced as an injury, there may be the development of adhesions, and indeed converting your polycystic ovary patient who was just polycystic ovaries to indeed a patient with a tubal factor. There are many studies that have shown that surgical approaches are not any more effective than gonadotropin induction and in fact have similar outcomes at achieving ovulation and pregnancy. And I think overall the sensible answer would be that the best second line choice is dependent on whether medical agents are available and the necessary monitoring that is required is available in that clinical setting. For me personally, I do not consider ovarian drilling as a good choice for patients because yes, I work in a setting where we have the available ability to monitor a patient, and I've seen too many cases where there is peritubal adhesions or there is too much damage through ovarian drilling. Something I would like to comment on would be that certainly when a patient is being considered for a surgical or indeed medical injectable line of a second line treatment, it is very important that if that patient was not fully evaluated by a primary screen, this needs to be completed prior to going to second-line agents, which are more costly with increased risks. So at a very minimum, there should be a semen analysis performed, and indeed in the case of a medical treatment, there should also be a tubal assessment done, if it had not already been done before. So let us now turn to other treatment options for infertility beyond ovulation induction. Intrauterine insemination involves the preparation of sperm and washed sperm being placed through the cervix up into the upper uterine cavity. IUI allows us to place the sperm much higher than intercourse would place that, and it would offer a benefit if there's a coexisting mild male factor, obviously without a tubal problem, or potentially a cervical factor. It may be considered in gonadotropin OI treatment cycles, and in part this is that as these are more costly in their medications, we sometimes will consider adding IUI to load that dice even further. What we're very clear on is that there's very little benefit to considering more than 3 intrauterine insemination cycles to achieving that pregnancy. At that point, it is time to turn to other options. In vitro fertilization for polycystic ovaries is something that certainly is not uncommonly required. It may be required because first and second line agents simply fail to achieve a follicle. And thankfully, this is actually a relatively low risk for patients, with only probably 5% of polycystic ovaries not responding to either first or second line treatments of ovulation induction. However, it may also be required if there are coexisting other factors. So for example, if at the primary screen we identify that there's a significant male factor or a tubal factor, well then obviously that becomes your primary and limiting diagnosis, and polycystic ovaries to a level becomes your secondary. Indeed, if we have tried adequate ovulation induction with a response and it fails to achieve a pregnancy within 6 months, in vitro fertilization would typically be the next step of treatment. The IVF process involves the preparation and start of the contraceptive pill and downregulation. It involves ovarian stimulation to turn the ovaries on using the injectable hormones, but at a higher dose with higher efficacy. We then retrieve the eggs directly from the ovaries, and therefore avoiding any impact that the tubes may have to this process. We fertilize the eggs and create embryos, which we then culture, and these will select a lower number of good quality embryos, from which we can choose embryos for transfer. The benefits of IVF in polycystic ovaries would be that the ovarian stimulation protocols are extremely effective. IVF obviously also treats other causes of infertility which may not be detectable through diagnostic tests. The average egg number at IVF is 12, and it's fair to say that the average egg number with polycystic ovaries is a bit higher than that. Embryo quality can be assessed and multiple embryos can be implanted to increase pregnancy rates. Success of IVF is dependent on age, but in young women IVF is extremely successful. What is the impact of PCO on the IVF process? Well, we know that patients with polycystic ovaries tend to have a higher response to medications, and therefore, in theory, there is a higher risk of ovarian hyperstimulation syndrome. Although this is much less with antagonist protocols, where the agonist trigger can be used in the event that someone does suddenly hyper-respond and produce 50 or 60 follicles, and this allows us to create a huge safety net. But patients with PCO typically are going to get good egg numbers. They're therefore typically going to get a good number of fertilized embryos. Yes, with some patients with polycystic ovaries, particularly your very severe polycystic ovary patients, there may be a tendency for this higher number to select to a smaller number of good quality embryos beyond what we naturally expect. However, as I already said, success rates are high and certainly dependent on age and quality of embryos. For many patients with polycystic ovaries, there will be surplus embryos, and these can be cryopreserved for hopefully future pregnancy. So how do we put this all together, from irregular periods to conception and a healthy pregnancy? So a logical approach for the polycystic ovarian patient who is now at a point in her life that she wishes to conceive would certainly be that, yes, best practice would be that a primary fertility screen would be done to include a tubal assessment and a semen analysis. The patient will then be commenced on oral OI and an ultrasound scan done to assess the response. In the event that we have a nice dominant follicle greater than 17 millimeters, we will continue on that level of ovulation induction for 6 further cycles. However, if that ultrasound shows that there is no response and indeed there is no dominant follicle, well, we will then consider either using a different oral agent or going to the injectables as the next step. Again, at any change, we would assess to see the level of response. And in the event that a patient is responding, obviously we continue for a total of 6 months, hoping she'll become pregnant within that 6 cycles. On the other hand, if even with the second line agent there is no follicular response, that patient then is best to go directly to IVF. So in summary, polycystic ovarian syndrome is a very common medical condition. It impacts on the quality of life, and there are long-term implications to health that can be reduced by limiting obesity. It has significant fertility implications. For the majority of patients with polycystic ovaries, they will require some level of management to conceive in most cases. However, ovulation induction programs are very successful in polycystic ovaries. Optimal management does include obviously ruling out coexisting causes by doing a tubal assessment and semen analysis, and performing ovulation induction with monitoring so we are sure that that treatment is inducing the correct response. Think like all patients being managed for their fertility or infertility as the case may be, it's important to establish timelines, so ovulation induction should be continued for up to 6 cycles once there is a response. Intrauterine insemination would be no more than 3. Because what is very frustrating for patients is often, unfortunately, to be treated with something like Clomid, for example, and then it doesn't work. No other options done. Patient goes to a different doctor. They're treated again with a similar regime. It still doesn't work. And sadly, it is not uncommon when I speak to patients and review their past management to find that patients may have been on ovulation induction regimes for years and with very little monitored, or indeed very little acceptance of, well, when do we decide to move on? IVF is sometimes needed, but the great news is that it does have good success rates. So lastly, let us focus on a myth that I so often have heard from young patients coming in to see me with polycystic ovaries. Well, I have polycystic ovaries, so my doctor has told me that I cannot get pregnant. Let us turn that into a truth and a perspective. I have polycystic ovaries, which means I will likely need some help to conceive when I am ready. But in the meantime, I will concentrate on controlling my weight and reducing my long-term implications. Thank you for listening to this webinar, and I hope you found it informative. There is further information about all of our treatments on our website, www.barbadosivf.com.
Okay, well, thanks again to Dr. Juliet Skinner and our friends at the Barbados Fertility Centre. We hope that this resource was a good one for those of you who tuned in. Again, for further information about the BAEP or the Barbados Fertility Centre, we have the links in the bio below. Thanks for joining us. We will continue to share information on our social media platforms about polycystic ovarian syndrome, so just ensure that you follow along. We are always willing to answer your questions, as well as the Barbados Fertility Centre. Remember, there is hope with PCOS. Thank you so much for joining us. We hope you have a great remainder of the evening. Good night.